Welcome to AETCM, the Emergency Medicine channel. Today we're discussing about a 70-year-old female who came to ER with complaints of acute onset of right side facial weakness with some difficulty in closing her eyes. Shall we begin? So, a 70-year-old female was brought to ER with complaints of facial deviation of one side of face to right side, and she had some difficulty in closing her eyelid since past one day. It happened the previous day night, but they couldn't come at that time, so the next day morning they came to the hospital. On my initial 10-second assessment, she was conscious, oriented, and obeying to my commands. So I went to the primary survey. The airway was patent. There was no signs of any airway obstruction. And breathing part, she had a respiratory rate of 18 per minute and SpO2 of 98% in room air. She had symmetrical and adequate chest rise, and chest was on auscultation clear and bilateral equilibrium entry. Circulatory part, her heart rate was 66 per minute and blood pressure was 150 by 90 millimeters of mercury. Disability part, she had a full score of GCS and pupils were 2.5 mm bilaterally equal and reactive. But her left eyelid kept open, remained open. On exposure part, she was efebrile and her GRBs was also checked was 135 milligram per deciliter. So in the primary survey, we didn't find any actual issues to intervene, and so we went with the secondary survey. So signs and symptoms. The patient was apparently asymptomatic yesterday morning, but by evening she started developing some difficulty in chewing, along with some drooling of saliva on the towards the left side, and also she felt some difficulty in closure of her left eyelid, and also she complained of some abnormal taste sensation since that day evening. And there was no history of any headache, nausea, vomiting, or anything. There was no signs of any seizure, epilepsy, or anything, and there was also no history of any auditory disturbance. But she had one history of fever one day, about 1 week back, only 1 day history, but there was no any focal signs. This 1 day history of fever was there. She doesn't have any non-allergic history. She's taking medications for diabetes and hypertension. Diabetes, she's on insulin, and hypertension, she's taking oral antihypertensives. And past medical history, she had a history of chickenpox about 40 years back. At that time, actually, they took some medications and were conservatively managed. And then last meal, about 3 hours before coming to the hospital, she had her last meal. And events as mentioned above. So from our secondary survey, basically she had a incident, not incident, about 1 day history of progressive weakness of one side of face with some difficulty in closing her eyes. No other issues, there's no other limb weakness or anything from the history. So clinical examination, she's actually a moderately built and nourished female, conscious oriented. She had some pallor, and then systemic examination, her
Some pallor means
means pallor was present.
is present or not?
Pallor was present. So there's no edema, there's no sinus or anything noted. Only pallor was there. Then respiratory signs, chest was clear, and other systems were within normal limits. So we went to the nervous system. Our higher mental functions were normal, so we focused on our facial findings. So basically, she had a weakness of her left side was not very clearly visible. So there was loss of wrinkling of her forehead on her left side, and also she had some inability to close her left eyelid, which we call the Bell's phenomenon. If we asked the patient to try to close her eyelid, there was actually uprolling of her eyeball upwards, and also there was deviation of angle of mouth to the right side, and she also had a history of drooling of saliva, and also bilateral sensory were actually normal. There was no loss of sensation or anything that she was complaining.
Sensation is supplied by which cranial nerve in the face?
Trigeminal, fifth cranial nerve. So this was our clinical examinations finding. So from our basic conclusion, there was nothing actually we could focus to any other pathology, like any acute CV or any other this thing, any recent. No, there was no history of recent trauma. There was no history of recent infection. There was no focus of any other limb weakness or anything. There was no history of any LOC, head trauma, or vomiting or anything like that. So we had a provisional diagnosis, most probable in favor of Bell's palsy. Okay. And we came to this actually by doing two things. That is actually we have to differentiate between whether it's a human or a LMN lesion. So when we actually tried to ask the patient to frown. When we asked the patient to frown, there is loss of motor supply over the affected side. So the left side actually there was wrinkling was lost. So which indicate there was an element facial palsy, because actually it was a central supplying lesion. Because of bilateral innervation, this will be maintained. So if you want to differentiate between a LMN and UMN, we can actually ask
So
the
you
patient.
think that element means both upper part and lower
Both
part
upper
is
part and lower part is affected.
UMN means
Usually the lower part will be affected.
upper part.
Upper part actually in rarely can be affected, but usually won't be because of bilateral nerve supply.
So it is the term used is a relative sparing of the upper part, because 50% is from right side, 50% is from left side. So one side is involved means 50% will be lost. In a severe weakness, even upper part can be involved.
No.
That we should remember. In a severe weakness, UMN type of weakness, sometimes upper part can be involved. That's why we call it as relative sparing of the upper part. Comparing with the LMN facial palsy, upper part is relatively spared.
So this patient had a weakness of the upper part. So it was more like a unilateral complete weakness, which is more in favor of a lower motor neuron palsy. Second thing is actually we want to rule out any other causes for this palsy. So there were the things we asked for, like any recent infection or any local lesions, like any herpes or anything local lesions. Then any history of any like previous stroke or any previous like severe like anything contributing like a stroke like symptom, but nothing was actually not in this patient. So it was more like an idiopathic cause. But
So
also
when you get a seventh cranial nerves palsy, you have three basic type of lesion. One is UMN facial palsy, that is associated with the same side weakness. You have right side facial palsy means right side weakness. The lesion is on the opposite side. Then you have a lesion in the LMN type of lesion, like what you told, facial nerve involvement of one side. There is no other clinical feature. In between, there is another condition. Patient is having one side LMN facial palsy, opposite side weakness. What is that?
just below the pons,
Where is the facial nerve nucleus situated in brain?
junction between pons and
Pons. You told correct. Pons. Okay. So if there is a pondine lesion on right side, you get right-sided facial weakness. That is
and opposite side hemiparesis.
Hemiparesis. That's called as what type of hemiplegia? It's called
Cross.
Basically, it is called as cross hemiplegia. Okay, so we should differentiate all these three types. Here you are telling only LMN facial palsy of one side, which is not associated with neither of what we told previously. So it is only individual cranial nerve involvement of facial nerve. Then once the facial nerve is involved, you are given a history of previous chicken pox. So how do you differentiate that? That is called as Ramsay-Hunt syndrome. What is Ramsay-Hunt syndrome?
Basically, the affected side will be having there will be lesions present.
So there will be lesion in the ear area. In the ear area, you can get like herpes lesions. Then cranial nerve palsy. That will be painful cranial nerve palsy. So here you have to see this is an LMN facial palsy. There is no other part of neurological system is involved, and there is no lesion surrounding the ear. Okay, so it has to be isolated LMN facial palsy of one side. That is called as Bell's palsy. Okay, what is Bell's phenomenon?
Phenomenon basically, if we ask the patient to try to close his eyelids, there will be uprolling of the eyeballs.
Okay.
Not
So
on the
normally
affected side.
when we close our eyelids, we can
close.
our eyeballs rolls upwards. But here we are not.
We are not seeing because of the closing of the eyelids.
The patient is not able to close. Okay. So as a ER physician, what is your role in that part? That your patient is not able to close the eyeball. What do you do immediately?
Thing is actually in the
you have to look for the patient will develop exposure keratitis. So immediately close the eye, put some pad and close it. That is your duty, because this part will be remain open for a long time if you don't take care of it. Ultimately, what will happen?
This thing, corneal abrasion,
ulceration, everything will occur. So our duty is to cover the eye immediately. Once you understand that patient is having LMN facial palsy, cover the eye. Okay, that is the first thing you do in ER. Then,
so first thing is actually we confirm or we try to a conclusion that this is more like a Bell's phenomenon, Bell's palsy. So the immediate mode of treatment is actually steroids.
Okay.
Which we can give oral steroids.
So before that, we have to rule out diabetes. So you rule out diabetes, then only we can start. Is there diabetes or not?
She has a history of diabetes.
Now what is the blood sugar? That is very important.
154.
So sugars are under control,
well
whether it is with insulin or
on insulin.
OHA. So she is already taking insulin. Okay. On top of that, you are going to give steroids. You are decided to give steroids. So slowly, you know that steroids will increase the blood sugar. So that you have to take care. Okay. So how do you give that?
We have to monitor the blood sugars in the following days after starting.
Okay, now you want to give steroids. What steroid? What dose you give?
Preferred is actually oral steroids, like prednisolone 40 to 60 milligram we can give.
Okay, every patient 40 to 60 milligram. What is the dosage of oral steroids?
1 mg per kg.
1 to 2 mg per kg body weight. You can give 2 mg also because it's a cranial compression in the track. Okay. So it will get destroyed if you don't give steroids. Okay, whether IV or oral you prefer?
Both have same bioavailability. So
both has got similar action, similar bioavailability, similar duration of action. Means once we start, it acts in 4 to 6 hours. The anti-inflammatory action starts in 4 to 6 hours. So whether it is IV or oral, both are same. Here we are given IV because it's available in ER. The tablets are not available, so we are given IV.
Initially we gave a Dexa 4 mg was given, followed by actually steroids were given.
Okay. How long patient has to be on steroids?
The usual recommended dose is 10 days.
Okay.
10 days actually we can also give 5 days 60 mg. Then we can give tapering dose. Every day we can reduce by 10.
Ideally, tapering is not required if we are stopping the drug in 2 weeks. Less than 2 weeks, if you are able to stop the drug, then tapering dose is not recommended. But if you are not able to taper in that 2 weeks, stop in that, then only tapering is required. When will you give steroids? In a day, what time you give steroids?
Preferably in the morning time.
Morning. Why not in the evening?
Because actually our body's natural rhythm is to produce cortisols in the morning time.
Okay.
So if you're giving it during that time itself, there won't be any irregularity in the hormones.
Okay. You want to give single dose or double BD dose?
Preferably single dose.
Single dose. So one of the most important mistake done by most of the doctors, they give it in the evening time. That should not be done. Then BD dose is not required when you are giving it as an anti-inflammatory drug. When you are giving it as a replacement dose for adrenal insufficiency, BD has to be given. Otherwise, now you give OD dose, preferably in the morning with.
Along with that, we can give valacyclovir.
No, that is
along with that, we can give a proton pump inhibitor.
Proton pump inhibitor or antigen, whatever it is, that has to be given. Okay, so that is for steroid. Then.
So studies have shown actually, even though there is no actual etiology for Bell's palsy, as a lot of studies have pointed out it's more in favor of a reactivation of herpes simplex or varicella zoster.
Okay.
So some studies have shown actually initiating on antiviral therapy have some benefits.
Okay.
So we also started him on valacyclovir.
Okay.
1 gram TAD was initiated.
So you can give acyclovir or valacyclovir, famcyclovir, anything is okay. Okay.
But the dosage, this thing will be more, patient will be more tolerable to valacyclovir.
Okay.
And also bioavailability is more in valacyclovir.
Okay.
So we can give 1 gram TAD for 7 days.
Okay.
So this patient we initiated that also.
Okay. What else you can give?
Then the third thing is actually for eye care.
Okay.
Eye care, initially we gave him lubricating drops and then give an eye patch to close the eyes.
Okay.
Suppose the patient is actually prefer to go out or something, we can advise him for any dark glasses to prevent direct sunlight.
Okay.
And also at home care, once he's going to sleep, we can go for eye lubricant can be given before he goes to sleep.
Anything else?
Physiotherapy.
So nerve stimulation has to be done. We cannot do it. We have to send to physiotherapy. Okay, that has to be done. What are the indications for MRI scan in Bell's palsy? So in ER, our duty is to start steroid, initiate on steroid, cover the eyes. Third one is decide whether MRI is required or not. Okay.
Usually, there is if you are suspecting or it's clinically pointing towards only Bell's palsy, there is no need for any MRI or further evaluation. You can immediately, it's more like a clinical diagnosis. But this presentation is more like an atypical presentation, or we are actually thinking about in any other differential for this cause, we can do an MRI.
Okay.
And also, if the patient is having progressive weakness over more than 3 weeks, or the weakness is persisting more than 3 or 4 months, then again we have to think about an imaging, not any other cause.
So if there is an associated other neurological finding, only MRI is actually required. In that MRI, you cannot go for CT also because you are thinking of pathology in the brainstem. So MRI has to be done. That itself, if you are watching or seeing any other neurological finding. Otherwise, MRI as such is not indicated in Bell's palsy.
So MRI actually usually preferred is MRI with contrast, so we can actually look for any space accumulations or any like abnormalities in the brain. And also, even if the patient is initially diagnosed as Bell's palsy, his progression we have to monitor. And if it is still persisting, we have to like go for imaging. If it is persisting more than 3-4 months with no improvement. Any case we are suspecting like any we can go for, the only indication for CT is actually if we are suspecting any like any lesions of the skull, anything like we are suspecting, then we can go for a CT. But otherwise, always MRI is the first option.
What are the other causes of LMN type of seventh cranial nerve palsy? Sometimes you can get bilateral cranial nerve palsy also.
We have to rule about think about other conditions like Lyme disease and AIDS.
That is not common in India. But you get Western like
sarcoidosis.
Sarcoidosis is very can present.
Then like CVA can also present like
CVA bilateral seventh
GBS, Guillain-Barré syndrome.
Miller-Fisher variant of GBS.
Then diabetes, like
diabetic neuropathy, not very common, but difficult to tell. Any other acute condition mimics bilateral facial nerve palsy. Acute condition we need to treat immediately. Myasthenia is not a good answer. The snake bite. Snake bite is one condition, especially crate bite. Crate bite can present with bilateral facial nerve mimicking. It's not facial nerve palsy, where the patient is unable to move any of the cranial nerves. So you can see that patient face is not at all moving. Okay, that also mimic facial nerve palsy. So snake bite, sarcoidosis, and syphilis also. Syphilis is not common. These are the few conditions. Lyme's disease you told. These are the few conditions which can have bilateral facial nerve palsy. What is mimic palsy? Mimic palsy means which mimics facial nerve palsy. Actually, patient does not have facial nerve palsy. It is Parkinson's. Patient will have facial palsy mimicking. So it is not actual.
There's no actual involvement.
And one more question is, how do you differentiate bilateral UMN facial palsy from bilateral LMN facial palsy? Is it possible? Very rarely you can get bilateral. These are all MD questions. Even if you don't answer, not a big problem.
Bilateral lower part will be affected in.
What you are doing now? You are smiling. Smiling is
emotions will be affected in LMN.
Emotions will be absent in
LMN.
Because emotion fibers are different from your facial nerve fibers. So emotions are not seen in LMN facial palsy. Emotions are preserved in
central involvement.
That is the answer. But as a ER physician, it cannot be required. For our duty is to understand whether it is LMN facial palsy or UMN facial palsy, whether MRI is required or not. Then once you diagnose facial palsy, cover the eyes, protect the eyes. Second thing, start steroids. Okay. Rest all things should be taken care by a neurophysician or physician. Okay. What else, sir? Anything? Okay. Anything you want to tell?
No, basically, as I said, actually, initial assessment, the patient, if you're coming with only a unilateral facial palsy, initially we have to assess whether it's actually an idiopathic condition or like or any other causes. Then differentiate between LMN or like a central pathology. Then we have to go for like imaging or something. So only in isolated injury with LMN features, we have to think about first stage Bell's palsy and then
taste sensation. Ideally, we have to do it, but in ER it is not possible. For us, it is not possible to do it.
So basically, a facial nerve is actually mixed nerve. So it has got different effects on different areas. So in the face, it will be affecting in the motor area, and the sensory will be more like in the anterior two-third of the tongue and also in the stapedius muscle. So patient can rarely have some like abnormal taste sensation or maybe an absent taste sensation and also some hyperacusis like symptom.
Patient may not normally facial nerve palsy patient may not tell about taste sensation because the opposite side is working. They may not complain. We can test and find out. Okay, it is a very difficult procedure, so we don't do it.
And then so the mixed component will be having affecting different areas, but there won't be like any sensory loss on the affected side. If you're touching the face, and not the patient will be able to perceive. So that's the clinical findings, and along with that, this thing, wrinkling of loss of wrinkling will be one of the classical signs which we can use to differentiate between LMN and central nerve.
Okay.
So treatment will be like, as I said, initially will be like a protection of eye, and then start or IV steroids as early as possible, and also especially there is a grading system which we call the House-Brackman classification, in which we have classification up to 5 grades, like from normal to severe dysfunction. So theoretically, a grade 4 or above, we usually recommend valacyclovir or other agents. In anything less than 4, we can even go for single steroids therapy alone.
Okay.
So that's the differentiation which we can, if we have got time, we can use that.
Okay.
So the treatment part, mainly we have 3 things. One is eye protection, then steroids and antiviral therapy.
When you are starting steroid, you have to see the blood sugar. It is going to shoot. Next day it will increase. So definitely you have to take more dose of insulin. So that has to be carefully monitored.
And so routinely the patient, even if you are not starting the treatment, they will recover in about 80 to 90% cases by about 3 to 6 months of time.
Okay.
Suppose the patient's symptoms are progressing over time, or it's not resolving by even more than 3-4 months, we have to ask them to review back for a further evaluation to rule out any other causes.
Okay.
And during this time, we can assess them for other like facial physiotherapy and all for like better and faster recovery.
Okay.
So this patient actually initial management was done in a year and then discharged for further management.
You have followed up or discharged?
Initially, the first day we admitted the patient. About third day, then discharged.
Okay.
Third day she was discharged.
Okay.
Okay.
Thank you.
Thanks.